I'm Dr. John Sweetenham, the host of the ASCO Daily News Podcast, with my top takeaways on selected abstracts from Day 4 of the 2024 ASCO Annual Meeting. Today's selection features 3 randomized prospective trials in the first-line treatment of multiple myeloma, adjuvant therapy for triple-negative breast cancer, and the frontline treatment of advanced renal cell carcinoma, all of which provide important new data. My full disclosures are available in the transcript of this episode. The first of today's abstracts is number 7500. This abstract, presented by Dr. Thierry Facon from the Department of Hematology at the University of Lille in France, describes the results of the IMROZ study. This was a multi-center phase 3 study comparing a current standard first-line regimen for transplant-ineligible patients with myeloma, VRD, with the same combination plus an additional agent, isatuximab. The combination of bortezomib, lenalidomide, and dexamethasone, known as VRD, is currently a standard first-line regimen for patients with multiple myeloma, both transplant-eligible and ineligible. Previous phase 3 studies have shown that the addition of an anti-CD38 antibody to triplet regimens improves outcomes in newly diagnosed patients. Based on early phase clinical trial data showing promising response rates with isatuximab, the IMROZ study was conducted to compare isatuximab VRD with VRD alone in patients who were either ineligible for transplant or had no immediate indication for transplant. IMROZ was a global study conducted in 21 countries that involved 446 patients, randomly assigned 3-2, to induction therapy with ISA-VRD, followed by continuous ISA-RD, or induction therapy with VRD, followed by RD alone. The rate of complete response or better was approximately 75% with ISA-VRD, compared with 64% with VRD alone. Very good partial response or better was achieved in 89% of patients with ISA-VRD, compared with around 83% of those with VRD alone. With a median follow-up at 5 years, ISA-VRD followed by ISA-RD had reduced the risk of progression or death by 40.4% compared with VRD alone. The 60-month progression-free survival rate was 63% for ISA-VRD, compared with around 45% with VRD alone, and the progression-free survival benefit was maintained in most of the analyzed subgroups. Minimal residual disease negativity was also measured in this study in both the intent-to-treat population and those patients who achieved a complete response. For example, in the intent-to-treat population, the MRD negative rate was 58% with ISA-VRD, compared with around 43% with VRD alone. There were also higher rates of sustained MRD negativity for 12 months or longer among patients assigned to ISA-VRD compared with VRD alone, reflecting deeper responses in the ISA-VRD arm. Although overall survival data is still immature, data from an interim analysis showed a favorable trend in the ISA-VRD arm, with 22.4% risk reduction compared with VRD alone. There was little additional toxicity from the inclusion of isatuximab with the VRD regimen, and the quality of life data were comparable and stable in both arms of the study. The investigators concluded that although overall survival data are immature, there is a trend in favor of ISA-VRD, and this, combined with the favorable response, toxicity, and progression-free survival data, establish isatuximab VRD as a potential new standard of care for newly diagnosed multiple myeloma patients not eligible for transplant. There was some discussion regarding the potential use of this regimen in patients over 80 years of age, since the upper age limit was capped in IMROZ at 80 years. Although there are concerns for tolerance of the 4-drug regimen in the older patient group, it seems likely that this will be adopted, especially for those with good performance status and without major comorbidities. Next up is the late-breaking abstract 500. This abstract reports results of the A-BRAVE trial. This trial, presented by Dr. Pierfranco Conte from the University of Padova, Italy, was a phase 3 randomized trial to assess the efficacy of the immune checkpoint inhibitor avelumab in 2 groups of patients, Those with early triple-negative breast cancer with residual disease after neoadjuvant chemotherapy, and those at high risk after primary surgery and adjuvant chemotherapy. As Dr. Conte explained in the introduction to this trial, there is a fairly compelling rationale for the use of checkpoint inhibitors in triple-negative breast cancer. The disease has been shown to be more immunogenic than the other breast cancer types, with immune biomarkers such as TILs and PD-L1 expression associated with better prognosis, added to which data in metastatic breast cancer show a correlation between PD-L1 expression and checkpoint inhibitor response. In the A-BRAVE study, 477 high-risk patients who had completed local, regional, and systemic treatment with curative intent were stratified according to adjuvant or post-neoadjuvant status and randomized 1-to-1 to receive avelumab at 2-week intervals for 52 weeks or to observation only. Results of the study showed a non-statistically significant improvement in 3-year disease-free survival in the overall intent-to-treat population at 5.1% and in the post-neoadjuvant patients at 6.2%. Overall survival was a secondary endpoint in this trial. The results show a significant improvement in overall survival of 8.1% in the intent-to-treat population and a very similar improvement in the post-neoadjuvant patients. The authors reported good tolerance of avelumab, although in total, almost 30% discontinued treatment at some point. In their conclusion, the investigators state that the 34% reduction in the risk of death suggests a potential role for avelumab in early triple-negative breast cancer patients at high risk after primary surgery or with invasive disease after neoadjuvant chemotherapy. Correlative studies are planned on tumor, plasma, and feces in this study. These are interesting and somewhat tantalizing results, suggesting a real effect from avelumab, although confounded somewhat by the sample size. It will be important to see how these results mature with further follow-up. Today's third selected abstract is number 4508, reporting the final analysis of the JAVELIN Renal-101 Phase 3 trial in patients with advanced renal cell carcinoma. This study compared the combination of axitinib plus avelumab with sunitinib in this patient group. The trial included 886 patients, of whom around 61% of those in the combination group and around 65% of those in the monotherapy group were PD-L1 positive. In the initial analysis from the JAVELIN Renal-101 study, after at least 6 months of follow-up, avelumab and axitinib significantly improved progression-free survival over sunitinib in patients with PD-L1 positive tumors and in the overall population with advanced renal cell carcinoma. In the full cohort, the median progression-free survival with the combination was 13.8 months, compared with only 8.4 months with sunitinib. And based on those results, the combination received FDA approval as a first-line treatment for patients with advanced renal cell carcinoma in May of 2019. The progression-free survival observed in the initial analysis was confirmed with a new long-term analysis in the overall population. Median progression-free survival with avelumab and axitinib was 13.9 months, compared with only 8.5 months with sunitinib, and the median duration of response with the combination was 19.4 months versus 14.5 months with sunitinib. However, no difference in overall survival was seen. At 60 months, the overall survival in the combination group was 38.8% and 36.2% with sunitinib. In patients who were PD-L1 positive, at 60 months, overall survival with the combination was 37.1%, compared with 33.4% with sunitinib. Despite the sustained difference in progression-free survival seen with this combination, the discussant at this session pointed out that most oncologists are unlikely to recommend a combination which has not been shown to improve overall survival, when published studies have reported on 4 combinations which positively impact overall survival in this patient group. Despite the good tolerance of this regimen, it seems unlikely to be a preferred frontline regimen in advanced renal cell carcinoma moving forward. That concludes today's report. Thanks for listening, and we hope you have enjoyed listening to our top takeaways from ASCO24. If you value the insights that you hear on the ASCO Daily News Podcast, please remember to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.